Welcome to the Healthy, Wealthy, and Smart podcast. Each week, we interview the best and brightest in physical therapy, wellness, and entrepreneurship. We give you cutting-edge information you need to live your best life, healthy, wealthy, and smart. The information in this podcast is for entertainment purposes only and should not be used as personalized medical advice. And now, here's your host, Dr. Karen Litzy.
Hey everybody, welcome back to the podcast. I'm your host, Karen Litzy, and today's episode is brought to you by Net Health. So Net Health wants to talk about something important, patients and their outcomes, specifically how great it is when your whole practice is rallied around a solid outcomes management program. So to learn how to do all of this, they are teaming up with Photo, which is Focus on Therapeutic Outcomes, for the Clinical Outcomes Summit, October 23rd to the 25th in Knoxville, Tennessee. But it's not just for Photo clients, it's a gathering of everyone who believes in the power of outcomes management to drive change for patients, clinicians, practices, and payers. You'll hear success stories and case studies from your peers, and there's going to be motivating and inspiring keynote speakers, including my good friend, Michelle Colley from Performance PT and Daniel Lord from Crossover Health. And Healthy, Wealthy, and Smart podcast listeners get a steep discount on the registration. Use the discount code Litzy, and the full summit pass is only $150. Go to www.outcomesnerd.com to register, learn more, and check out the agenda. And now on to today's episode. I am so happy to welcome to the podcast Dr. Daniel White. He is an assistant professor at the University of Delaware in the Department of Physical Therapy. His research focuses on physical activity and physical functioning in older adults, people with knee osteoarthritis, and people after joint replacement. His research uses large existing data sets to answer questions related to physical functioning and physical activity. As well, he is also conducting clinical trials to lead ways to better promote and increase physical activity in people with knee osteoarthritis and after joint replacement. He is an associate editor for Arthritis Care and Research, an active member in the APTA, the American College of Rheumatology, and ORC. And in today's episode, we are discussing clinical practice guidelines. What are their roles? What is implementation science? The latest research findings from the Physical Activity Lab at the University of Delaware, for which Dr. White is an assistant professor at the University of Delaware in their Department of Physical Therapy, and limitations of physical therapy branding and how we can step into physical activity space. So I want to thank Dr. White for coming on, for talking all about clinical practice guidelines, the evidence behind them, and how and why they should be used. So everyone, please enjoy. Hey, Dan, welcome to the podcast. I'm happy to have you on.
Thanks. It's great to be here.
And now today we're going to be talking, amongst other things, implementation science. So before we go any further, can you give a definition of what implementation science is?
Absolutely. So implementation science, the definition is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine practice, and hence to improve the quality and effectiveness of health services. So essentially, it is bridging the gap between science and practice, and it is taking things that we find in laboratories and in clinical studies and literally implementing them into real-world clinics where most physical therapists work.
Right. So then my other question was, why should the average PT care? Which I think you just explained that. So we need to care about implementation science because this is how we're getting what researchers do in the lab to our real world situations and our real patients, correct?
Yeah, I think practicing as a physical therapist, you can look around and a lot of people do a lot of different things and a lot of things seem to work. And I think if we want a game changer in our practice, that is going to come from systematically studying people and understanding what are the underlying critical ingredients of our practice that really work. And the best thing we have made up to date to answer that sort of question of, what is it that really works are clinical practice guidelines.
Mm-hmm.
That is essentially the best body of evidence that has been reviewed by a panel and vetted and made to be digested by the everyday clinician, and implementing these clinical practice guidelines are really the key element that is going to lead to a game-changing opportunity for us as a profession.
And when you talk about clinical practice guidelines, I know sometimes people think that you're doing it's cookie cutter. And what do I need to follow a cookie cutter recipe for? Because all of my patients are different. So can you speak to that?
Yeah, no, that is a great point. Okay, so on the one hand, there is definitely a art to physical therapy, and the clinical practice guidelines and evidence-based practice is by no means trying to take that away. It's evidence-based practice in general is not cookbook medicine. It is combining the three things, and one is what the evidence says, but two, it also combines what the therapist's experiences are, and then finally, it's what patients' preferences and what their feelings are on the whole thing. And it's a combination of all three. It is literally the definition of evidence-based practice. And these clinical practice guidelines are definitely consistent with that EBP model. So they are not directions, or they're not instructions. They're guidelines. They are ways of helping people make informed decisions. And at a minimum, if you consider yourself an expert clinician, knowing what the clinical practice guidelines are is a big leg up, and definitely key to helping our profession. Doesn't necessarily mean you ascribe them to every single patient. No, that's not what evidence-based practice is. But being aware of them is, by definition, in my opinion, being a good clinician.
So can you give us an example of one of these clinical practice guidelines?
Sure, absolutely. So one of the common patient populations that people treat is low back pain. And Tony DeLito and his colleagues at University of Pittsburgh and elsewhere developed clinical practice guidelines for low back pain and published this in JOSPT in 2012. And basically, in their paper, described that the purposes of these CPGs are first to describe what EBP is for physical therapy practice, and then also to classify and define common musculoskeletal conditions, from which, from this classification criteria, specific interventions are devised. So, for an example, I don't treat low back pain. This is not my area. So, forgive me for giving a guess here. But the diagnosis classification for low back pain, one example is lumbosacral segmental somatic dysfunction, and this is associated with an ICF diagnosis of acute low back pain with mobility deficits. And Tony goes on to saying that there's certain clinical findings with this, including acute low back pain, buttock or thigh pain, restricted lumbar range of motion, and lower back pain and lower extremity related symptoms with provocation. And then from that, there are specific interventions that I'm not going to get into that are supposed to be had, and that is unique from a different classification. So a different classification of low back pain is subacute low back pain with mobility deficits, which is highlighted by having basically not acute but subacute pain, and the symptoms are produced with end-range spinal motions, and there's a presence of thoracic lumbar or pelvic girdle mobility deficits. And then he goes on, and there's different these different classification criteria from which there are very specific interventions you're supposed to do. So it's classification and then intervention based on that. And essentially, that is, in an ideal world, what a CPG should do. However, you're always going to have the patient that really doesn't fit into one or the other. Let's have somebody who is not quite acute, but they're not quite subacute. So what do? And I think being able to first even make that distinction, you have to be aware of the clinical practice guidelines. So knowing that, okay, maybe it's going to be a combination of these two interventions because this person doesn't fit into either one. But see how that approach is already a leg up from not knowing what CPGs are to begin with and what are common classifications. Does that make sense?
Yeah, that makes a lot of sense. Thanks so much for using that as a really great example for people. And when you're talking about different CPGs, I know that the Academy of Orthopedics, which used to be the orthopedic section of the American Physical Therapy Association, they all have these different names now. It's just made it all so much more confusing. But now, obviously, big proponents of the clinical practice guidelines. But if I'm the average clinician and I want to find some of these guidelines, where do I go? How do I find them?
Sure. So all the published clinical practice guidelines for orthopedics are on the Academy of Orthopedic Physical Therapy's main webpage, which is orthopt.org, orthopt.org. And there's a banner that says CPGs, and you just click on that, and you can get right to all the published CPGs.
Awesome. And we'll have a link to that in the show notes at podcast.healthywealthysmart.com under this episode, so that if people need it, one click and we'll take you right there. So there's no excuse to not know these CPGs after listening to this podcast then, because we're going to make it really easy for you. And now, you just gave us a good example of how CPGs can work in clinical practice. Are there times where maybe they don't work so well, or is there a downside, I guess is what I'm trying to say?
Yeah, I mean, again, going back to your original question of, is this cookie cutter medicine? And it's not. And again, since EBP is that combination of patient preference, the provider know-how, and what the evidence is, I mean, there's going to be situations where, a situation's weighted much more towards a patient's preference. Like they don't want you to do manipulation, or maybe they want something specific, and you're like, well, that's really not called for in this case. And so you don't do the intervention that's prescribed or that the CPG recommends. And that's okay. We're not here to tell people to command them what to do. They're coming to us for help, and patient preference is a large part of evidence-based practice. I think, that's the best example I can think of.
Yeah, and I think if you're looking at your clinical experience as one of the legs of that stool, if you will, and the patient doesn't have a preference, yet you're sensing as a clinician that there's some trepidation on the patient's part, there's some fear, if you were to, like you said, we'll take a manipulation as an example, then using your provider know-how, you would say, this is not the right time or place for this. And
right.
So I think you've got all of that in combination. So the CPGs is not a cookie cutter, just because A, B, C, and present, you have to do treatment B or treatment A or B, but instead it's giving you a way to maybe differentially diagnose and a way to, be able to maybe give your patient an explanation as to what's going on, and then use your judgment, use the patient preference and the evidence to then guide your treatment.
Yeah, exactly. It's just like, when you just meet somebody, you try to figure out who they are, right? And you try to figure out what kind of personality they are. And there's some sort of structure or rubric people use. Like, let's say there's introverts and extroverts. Is this an introvert or extrovert? In the CPG, the first thing that it does is provide you a framework of saying, well, what kind of types of people are there with this type of pathology? You know, they a type of person that has, I don't know, this type of disorder, or this type or another type of disorder, and from that diagnosis of providing a classification, there are clear treatments associated with that. So back to the party analogy, you know, if you're dealing with an introvert, you know that they're not going to be super bubbly and all over you. You have to kind of bring things out of them, and maybe take it easy, and, you know, take it on the slow road. Versus if someone's an extrovert, maybe they're going to be doing all the talking, and you can just be an active listener and be very interested in what they're saying, because they're the extrovert, and perhaps, you know, that's kind of how it goes. And the CPGs is essentially just it is in the party analogy, a way of just navigating through our clinical practice to provide best care. And, you know, I think another medical example that really stays fresh in my mind is sort of life-saving approaches to acute MIs. And it wasn't the sort of protocol or clinical practice guidelines for myocardial infarction weren't developed when necessarily right after science discovered that, you know, look, if you do X, Y, and Z, you can actually save someone's life. That came much later, and it wasn't until I think it was at University Hospital in Chicago implemented these sort of CPGs for life-saving approaches to MI, that the death rate for acute MIs went way down, and all the medical residents followed this CPG for treating acute MIs, and that systematic approach is what made care better. Obviously, in physical therapy, we're not talking about life or death, but these CPGs have been vetted and are an approach that, if systematically used, will produce better outcomes. So yes, it's, you know, EBP. I'm not changing my story here. EBP is obviously patient preference, provider experience, as well as the evidence. But when applied systematically, which means be at minimum aware of what the CPGs are, they should produce better outcomes system-wide.
Yeah, and thank you. I think I love the party analogy, and comparing it to that medical example really kind of makes the CPGs a little bit clearer. And hopefully people will now not look at them as some sort of cookie cutter program, but instead as a way to help inform you of your practice, which I think it's great. And now, all right, so let's move on from CPGs. Let's talk about, I'm kind of interested into what you're doing next. So you are the director of the Physical Activity Lab at the University of Delaware. So let us in on some of the things that you guys are working on, if you can. You know, I understand you can't say everything, but what are some things that you're working on that you feel like will be part of future implementation science for the average physical therapist treating patients like myself?
And on that note, we're going to take a quick break here from our sponsors, and we'll be right back.
Let's talk about something important: patients and their outcomes. If you love to nerd out on this kind of talk like I do, the best industry event around outcomes management is happening from October 23rd to the 25th, and it's the Clinical Outcomes Summit. It's hosted by Photo, but it's not just for Photo clients. It's a gathering of everyone who believes in the power of outcomes management to drive change for patients, clinicians, practices, and payers. And the best part, Healthy, Wealthy, and Smart podcast listeners get a steep discount on the registration. The full summit pass is only $150. At that rate, go ahead and bring your entire team. Go to www.outcomesnerd.com and use the discount code Litzy. That's Litzy. Hope to see you there.
Thank you for the opportunity. You know, for my whole goal is just to get patients better. And I worked in inpatient acute rehab for several years, and I always wondered, you know, after I got people independent with bed mobility transfers and ambulation, would they actually take those, newfound independence and actually resume their daily activities and be active in the home? And that led me to really thinking a lot about this notion of physical activity, or how much do people do? And so in the area I study it's osteoarthritis, and osteoarthritis is a serious disease that is associated with higher rates of mortality. It's common, affecting millions of people. And one of the only definitive treatment for osteoarthritis is total knee replacement. Now, after total knee replacement, people do great with improving their pain and increasing their function. But there's many systematic studies that show, in terms of physical activity, people aren't doing more. They're doing just as little as they did before. And I think that's a real missed opportunity for physical therapists. And I think there's a great opportunity to talk about, being more active and helping patients. And it really doesn't take that much. It's just hey, so, how much are you doing every day? With smartphones and the use of Fitbits, counting steps per day is actually an incredibly effective way to increase, or one, to see where people are at in terms of physical activity, and two, to increase how much activity people are doing. So just like if you're trying to lose weight, you usually have a scale, and you want to see how much, where you're at and what progress you made. Using a pedometer or using a Fitbit monitor to count your steps is an analogous way of doing the exact same thing. So at the University of Delaware, we are studying ways to, what are the best ways physical therapists and practical ways physical therapists can increase activity in people with knee replacement. And what we've done is we recently published a study that basically found that, one, it's very feasible to, talk about physical activity and do a really quick intervention for people after knee replacement by simply giving them a Fitbit monitor and seeing how many steps per day they're walking, and then increasing that number of steps per day. What our target goal is 6,000 steps per day. In a study we did several years ago, we found people with knee osteoarthritis who walked at least 6,000 steps per day were much less likely to develop functional limitation than people who walked less than 6,000. So that's where we use the 6,000 steps per day.
I was just going to ask that question.
Yeah, that's where we have the goal set up, and we since there's a health outcome associated with 6,000 steps. We ask patients to, that's our goal, and we see where people are walking, and then we start to increase their steps by 5 to 10% per week. So if you're walking 2,000 steps, we increase it by 500 to 1,000 steps. 500 to 100 to 200 steps per day more. And then the next week we see where they're at, and we increase it again by another 5 to 10%. And what we found doing this intervention in physical therapy is that 1 year after discharge from physical therapy, so they've had no physical therapy and no intervention, people pretty much maintain the gains they made in physical activity. And their gains are pretty substantial. There was a high percentage of people that met the 6,000 steps per day goal and maintained that 1 year out in a preliminary study we did. And we are currently collecting more data to look at this in a larger sample to have a little more robust results. In talking back with the theme of implementation science, what our next step is to implement this intervention in real-world physical therapy clinics. We recognize, at the University of Delaware, we have a fantastic physical therapy clinic, but our clinicians and the type of patients that come here don't represent a cross section of the entire country.
Sure.
We want to see whether this intervention can work in real-world clinics, and we've partnered with a clinic in Lancaster, PA called Hearts Physical Therapy, and we're looking at developing a implementation of our intervention at that clinic to see, how this takes, what's the uptake with clinicians, what are the barriers, what are the uptake with patients, what are the barriers, and how can we make this thing, this evidence-based practice approach actually work? So that answers your question.
Yeah, and I was, as you're saying that, I'm thinking, well, does it matter? Like, these people know that they're in a study, so is that their incentive to, continue on with getting these 6,000 plus steps in a day? Because we all want to show the teacher that we're good at what we do.
Yeah.
Right. And
Yep.
then the question is that enough? Like you said, you followed them for a year to really make that a lifestyle change. And maybe after a year it is.
Yep. No, those are good questions. So in terms of the in terms of like a Hawthorne effect, where you're just doing this because you're in the study. First we do have a control group that wears the monitor, and they did not have the intervention, but we are monitoring their physical activity, and they know it. And the intervention group in our previously published study in Arthritis Care and Research, that the intervention group still is walking almost double of what the control group does 1 year out. So that's notable. And then in terms of I forgot what your second question was.
Oh, it was, did you find that, 1 year is a long time. And at that point, do you feel like it has shifted to just a lifestyle change?
Yeah, no, that's the encouraging part. Like 1 year out, that's a pretty good outcome for not having any contact with health. Well, not having your original physical therapy for your replacement, and that's incredibly encouraging for a long-term outcome, and actually thinking that there might be large behavioral change. Another interesting thing with our preliminary study is that we looked at the adherence or the fidelity of treatment in the physical therapy clinic. And what that means is, how often did physical therapists tell the patient about, ask them about their step goals and ask them about, how they're doing. And it actually wasn't that great. It was around 50%. So it wasn't that this intervention was, so well taken. In my mind, it was more that the patients really grabbed onto this and saw that, look, this monitor tells me exactly where I'm at. And in qualitative studies we've done, or interviews we've done after the intervention, the patients, by and large, they say, look, I know where I'm at. That this monitor tells me, and I know when I have a good day and I know when I have a bad day and what I need to do to make a difference between the two.
That's great. And if you can get that from the monitor, the Fitbit or the pedometer or whatever it is that you're using, then I think that's a huge win. Excuse me, a huge win, not just for mobility, which obviously we know we need as we get older, and especially after knee replacements, but for a whole host of other health reasons as well. Yep,
exactly. I was just lecturing yesterday to newly minted rheumatology fellows at UPenn in Philly, and talking about physical activity. First, it was interesting to know that none of them knew what the physical activity guidelines are, which maybe, most people don't know what they are, but it's 150 minutes of moderate intensity activity per week you're supposed to do, or 75 minutes a week of vigorous intensity.
Right.
And the reason why these guidelines are so important is that the benefits of health, of being physically active, are far-reaching. They vary. They range from not only improved strength and flexibility, but you also have cardiovascular benefits. You have mental health benefits. There's less chance of depression. There's less chance of weight gain. There are a lot of far-reaching effects, even so that the American College of Sports Medicine jokes that if you could put the benefits of exercise into a pill, you would have a blockbuster pill. I mean, everyone would take this pill. It's definitely a huge benefit to be active. And then the second thing is that, for a physical therapist, is that something we should address? I mean, that could be something that,
Yes.
typically, typically, well, therapists, you think the patient comes in, they have their complaints, and, let's talk about, reducing your pain and increasing your range, and then getting you back to, where you were at. But a recently published study in physical therapy actually surveyed patients and said, what do you feel physical therapists should talk about? And they asked them a range of things, including weight and diet and physical activity. And by and large, it was 90+% of patients said, I want my physical therapist to talk about physical activity. That is what they're there for. That is a major reason I'm here, and I want them to ask me about it and to counsel me on it. So I think that's something we should, to embrace and understand, what our guidelines, this 150 minutes a week, understand that, and understand, what our steps per day, what are sort of major benchmarks for steps per day. We oftentimes people say 10,000, but, we found earlier that 6,000 for people with knee osteoarthritis is a meaningful benchmark. And then, and the last thing I'll say about the physical activity thing is that American College of Sports Medicine in their the physical activity guidelines from the Department of Health and Human Services, their major recommendation in it before the time one is that it's the saying that some is good, but more is better. That there's a dose-response relationship between how much activity people do and their health benefits. So even getting somebody who's completely sedentary to doing at least walking for 5 to 10 minutes a day is a huge change in their health outlook and risk for future poor health outcomes. So that is a major thing that PTs need to keep in mind is if I can get this person who I know is sedentary just to do something and adopt that, that could be a huge gain and a huge win for this patient.
Yeah, and I think that the physical therapy profession needs to really step up and be the people to step into this space. I mean, this is what we do. This is our space, We should be grabbing those patients who maybe have knee OA but don't need a knee replacement yet.
Yeah,
we should be stepping in. That's our jobs. That's what we should be doing. We should be working with obese or sedentary people of any age before they have to come and see us for an injury.
Yep, exactly. My doctoral student, Meredith Christensen, who worked with Jillian Hawker at the University of Toronto to do this qualitative study on primary care physicians. And essentially the question was, why don't primary care physicians recommend exercise and physical activity to patients with knee osteoarthritis? Although despite the fact that every single clinical practice guideline for knee OA recommends, exercise, by and large, the primary care physicians were saying, well, we don't know what to recommend. We're not the experts. And they would like to refer their patients to PT, but it's not reimbursed up in Canada. So, I think this further underscores the notion that as physical therapists, we should own the physical activity sphere. We should be the ones that people think of like, well, I want to be active, but I have some problems. What do I do? Go see a physical therapist. We are highly educated individuals who know more about biomechanics, more about kinesiology than anybody else in the clinical sphere. And we are the best place to make exercise and physical activity recommendations to people of all types, more so than any other health provider.
Yes, I couldn't agree more. I could not agree more with that. And in my opinion, and my hope is that physical therapy really starts to move toward that in the very, very near future. Because boy, could we make a big impact in the lives of people around the world if we're that sort of first first line of defense, if you will.
Yeah. Yep.
And isn't it amazing that, like, it's so, I love that you brought up, well, it's not covered by insurance, but people will go and pay for a trainer or a massage therapist, a Pilates, yoga, and it's not knocking any of those professions at all, because I think they're all very valuable. But people will pay for that and not say, well, can you turn it into my insurance?
Yeah. Yep.
And then when it comes to physical therapy, where, you know, we know all this stuff, we have the guidelines, we have the clinical prediction rules, we have the education, and it's just not something that people are willing to put money down for.
Yeah, I think, well, there's two things. One, I think that, I think people will pay if they see value in it. And
Yes.
I think that it's not that we don't have value, but I don't think we're marketing ourselves well as physical to the larger community. So going back to the implementation science, the CoStar sponsored implementation conference and workshop, implementation science conference and workshop in Providence, Rhode Island this past March. And the president of the APTA came and spoke there. And he said that, you know, for us as physical therapists, we're really lacking in the sales and marketing sphere. And one of the reasons why is because, well, one of the things is we all call ourselves physical therapists. But what that means is very different depending on where you work. So, for instance, you know, a patient is going to have a view of what a physical therapist is at their first contact. So if they see a physical therapist working in a school, well, they'll think all PTs work in a school. Or if they see them at the acute care after a major MI, well, then they think they only work at acute care. But, you know, marketing that we actually are versed in many areas is a challenge we have. And I don't know if that means we start to call ourselves a sports specialist or, you know, cardiac specialist or what, but, you know, something along the lines of marketing our idea or marketing our expertise better is a key area of need. And then the second thing is, you know, I think it's okay to ask people to pay for things. I think if in my area, in knee osteoarthritis, people will pay $5,000 to $10,000 for stem cells or PRP injections. And, you know, the evidence behind that is, well, let's say it politely, much lower than what the evidence is for exercise in knee osteoarthritis. All right. And it's just incredible that, you know, if someone's going to lay down that sort of cash, you know, I think there is a definite market out there for services that are viewed as valuable, and having a physical activity or exercise prescription that's tailored to, you know, individual needs, you know, is a clear area of opportunity for our profession, for people with chronic diseases, and, you know, I think is a space that we should definitely pick up and be in.
Yeah, there's no question. I could not have said it better myself. And now, before we wrap things up here, it's the same question I ask everyone. And that is, knowing where you are now in your life and in your career, what advice would you give to yourself fresh out of school?
Yeah, that's a good question. I think the advice I'd give myself is, just do your best to make your patients better. I think that's all it is. And, you know, at the University of Delaware, we have a large, we have people here that work in very different outputs. So we have our clinical faculty that are working, doing a bulk of the teaching to the students, and then we have research faculty, our tenure track that teach the PT students, but all have our own research lines, and then we have clinicians that are working in the clinic. So very different outputs, but our goal is all unified, and that is just to help patients get better. That, you know, and from the clinical side, we're, you know, focused on excellence in research or excellence in teaching students the best and latest up-to-date things and the most effective ways to teaching them so they remember, not only to pass the test, but to have successful careers. And then from a research perspective, we're trying to look for, what are game-changing discoveries to help treat people and help them get better. And then the clinicians are implementing that on a daily basis at the University of Delaware. And, again, what makes us, I think, what I think is a prideful point is that we're all aligned in our goals with trying to get people better. And so that's something that I guess, I've always described to as both as a therapist, as a doctoral student, and now as a clinician scientist, is just trying to, my major goal is just to help people get better. So hopefully that's a good answer.
That's a wonderful answer. Thank you so much. And where can people get in touch with you if they have questions?
Sure. So my email address is dkw@udel.edu. That is D as in Dan, K as in Kent, W as in White @udel.edu. And feel free to email me anytime.
Awesome. Well, thank you so much. Thanks for breaking down the clinical practice guidelines and implementation science. And I love the stuff you're doing in your lab. So thanks for sharing.
Great. Thanks so much for having me.
And everyone else, thanks so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.
A huge thanks to Dr. Dan White for coming on the program today. And of course, a big thank you to our sponsor for today's episode, Net Health. So Net Health wants you to come to the Clinical Outcomes Summit, October 23rd to the 25th in Knoxville, Tennessee. You'll hear from rehab therapy pros from hospitals and private practices as they celebrate, examine, and define outcomes management. They've got some great keynote speakers this year, including my good friend Michelle Colley from Performance PT and Daniel Lord from Crossover Health. Healthy, Wealthy, and Smart podcast listeners get a steep discount. Use the discount code Litzy, and the pass is only $150. Go to www.outcomesnerd.com.
Thank you for listening, and please subscribe to the podcast at podcast.healthywealthysmart.com. And don't forget to follow us on social media.